Welcome to the Red Clinic podcast. I'm Dr. Schwalen, licensed psychologist and expert in the treatment of eating disorders. Today, I would like to talk about the different levels of care in eating disorder treatment. So thanks for joining us today. I think today is a real important topic. This is something that actually comes up a lot with the clients that I work with, and it has been a real common concern that has come up across the years that I've been working with clients who have eating disorders. So clients, families, loved ones, it's just real common to wonder, what are the different levels of care? When a recommendation is made, why is that the appropriate level of care? How do I know that the provider is really leading me in the right direction? What are all the things that go into even making that determination? And so that's some of what I'm going to talk about today. So first I want to start with what are the levels of care. There are several levels of care, and it can get really confusing. So I'm going to start with the highest or the most intense level of care, and then I'm going to work myself down to get to the lowest level of care. So residential level of care. This is when someone requires 24/7 care, meaning they are in some type of treatment facility. And usually the word residential is used because it's more like a living scenario. So the person will go to this level of care and they'll essentially live there for, just an amount of time that's appropriate for their needs. Usually in residential settings, the team or the treatment team, they all have expertise in the treatment of eating disorders. Many of them have expertise in dual diagnosis, meaning maybe the eating disorder is not the only thing that's going on with somebody. Maybe there's something like a substance abuse disorder or something else of real concern that absolutely needs some attention. And going and living at the treatment facility allows for a big enough shock to the system to occur so that the person who is dealing with that, either the eating disorder or the dual diagnosis, has to be almost forced to change their patterns, right? So we know that when someone's meeting criteria for an eating disorder, they can be really trapped in a set of patterns that are not helpful. Just depending on what the different eating disorders are, we know the behaviors can look different. Nonetheless, people do describe feeling controlled by those behaviors or thoughts or feelings. And so the residential setting allows for the person to be forced out of the normal routine. The team at the residential setting is usually multidisciplinary. So what that means is there's a lot of different people who work there, and they all have different areas of expertise. And the key is that they work together so that they can consult and collaborate over the person's care and make the best decisions for them. So usually you're going to find people like doctors, so medical doctors who usually specialize in some kind of psychiatry. Sometimes it's adolescent psychiatry or child psychiatry, and sometimes it's adult psychiatry. But nonetheless, there'll be someone there who can help with making decisions about medication management, but then also medical decisions. Because we know at the residential level of care, someone is usually struggling enough to not be considered safe. So what that means is they have to be under 24/7 surveillance almost, and they need that intense level of intervention to even start to feel better. So I'll explain that in a second, like in terms of what are the indicators that someone would even need that level of care. The other people on that team are going to consist of usually licensed psychologists who have expertise in eating disorder treatment, therapists who also have expertise in eating disorder treatment, who do a lot of the counseling and run the group therapy sessions. And then there's probably going to be some nurses on staff. Those nurses tend to be psychiatric nurses, so they have specialization in eating disorders or other psychiatric disorders. And so they are very strategically placed in a setting like that. So if there are medical needs, the nurses can tend to those medical needs on a daily basis. And then there's usually people on the team that are either called techs or milieu therapists, but no matter what they're called, they are the people who kind of walk through the environment day to day, minute to minute with the clients. And so those are the people that support the meals. They kind of sit down and talk about feelings throughout the day. They might direct the clients to where they're supposed to go next. They're really there managing the floor, right? And making sure everything moves along smoothly. They're also there to provide emotional support when needed in the moment. And that's what's really powerful about, higher levels of care, is that because it's during the meal, and that might be where someone who has an eating disorder becomes very triggered, they can have that in-moment support from another professional who has expertise in the area and who can respond to them immediately. And it's beautiful for trying to break patterns, right? So, we get on-the-spot coaching, we get on-the-spot support in the moment when the challenge is showing up. So during meal times is one of those biggest times for someone who has an eating disorder. Now, that's kind of a general overview of residential care, and not all residential treatment centers look the same. So I kind of gave you an idea of the types of professionals in that setting. There are some residential treatment centers that don't emphasize the medical piece as much. They may not have a physician on staff, but they might only have a nurse on staff. But somehow, some way, they'll try to find a way to cover that medical need. Now, inpatient hospitalization is kind of the step down from residential. It's not as long-term as going to live somewhere and receive, 24/7 intervention per se. Inpatient's meant to be more short-term. So residential and inpatient, the goal really is, from a medical standpoint, to stabilize a patient. Usually if someone needs inpatient or residential level of care, it's because medically and psychologically, so from both perspectives, they're in real danger. So this might be when an eating disorder is so extreme that someone's life is now at risk. And so examples of why someone might need to go inpatient, usually for an eating disorder, are for 3 reasons. The first reason is maybe they're a danger to themselves. So maybe they're having thoughts of wanting to end their life. Maybe they have a plan for how they would do that. And so they are not able to commit to some kind of safety plan. And so if we were to kind of let them out of our sight or let them go, we're putting them at risk, or we know they're at risk for actually following through on a plan to hurt themselves or to end their life. And so for that reason, it's considered that they would need 24 hours surveillance and just someone there to support and help them. Another reason why someone might be admitted inpatient if they have an eating disorder is because they may be engaging in some really dangerous purging behaviors. So if that's the case, when I meet people, for example, who meet criteria for bulimia, and I'm doing my assessment, I want to know how frequent are the purging behaviors? What types of purging behaviors are they engaging in? Sometimes I hear things like, a client may be purging 5, 6, 7 times a day, and essentially every time they eat, they're going and they're purging. And so to me, that's a red flag. That's very dangerous. There's a lot of things physiologically that they could be doing to affect their physical health. But from a psychological perspective, it also seems almost like this pattern has a very tight grasp on the person. It's kind of an obsessive and compulsive thing that they're engaging in. It's definitely interfering with their functioning. It's happening numerous times a day. They may describe being very secretive about it, so family members may not even know that it's happening at all. And if they do know it's happening, they might not know it's happening as often. And so in that case, that would be a situation where inpatient would probably be very likely for that client because they need help. I alluded to, shocking the system enough to get someone out of their routine. If we tried to manage that kind of case outpatient, that's only 1 or 2 hours a week out of an entire week with many, many hours and many days of not being in treatment or in front of a professional. There's no way that that person, there's very slim chances that that person may be able to stop those behaviors completely on their own. And so what I like to say, in the case of eating disorders, is that it really does take an entire army of people to kick the eating disorder to the curb. If someone could do it alone, they would have done it by now. So help and support is absolutely needed and common. It's very normal when we're trying to fight an eating disorder. The third reason that someone would need to be admitted inpatient is if they were just so physically malnourished and underweight that it was very dangerous for them to not be monitored through the night. And so we see this in eating disorders like anorexia or avoidant restrictive food intake disorder, when someone has become so malnourished that they're at risk for heart failure. And so being monitored even through the night, because it's questionable that, we don't even know if they'll make it through the night, is important in that situation. And so nursing staff, usually at the inpatient and residential levels of care, actually go in to the patient's room in the middle of the night in increments of time, so maybe every couple of hours, and check vital signs and monitor the patient's well-being. And even though that is disturbing to the client's sleep, sometimes it's necessary when a client has gotten to a certain point that they are medically unstable and considered at high risk for maybe heart failure or any other reason for like a sudden death. And so when inpatient is recommended, it's usually for a very serious reason, and the recommendation should not be discounted. I've met many clients who are very afraid of that recommendation. It's very hard for them to imagine putting their life on hold and going to the hospital, let alone having to spend the night there for several weeks. So inpatient can be, up to 3 or 4 weeks. It just depends on the client. Usually it's not much longer than 3 from what I've seen in my experience, because it takes that long. It takes that long to get someone stabilized. It takes long to nutritionally rehabilitate someone just enough to get them feeling better and thinking a little bit more clearly. And then they can step down. But my clients usually will say, this is horrible timing. I have to apply for college in the next few months, or things just ramped up at work and they really need me to be present. I can't take time off. And so there's a lot of reasons why someone can find that it's very difficult to step away from the normal routine of life. And there's a lot of argument against it in my experience. And my response to that is, hey, if we do this right the first time, you won't have to do this again, right? And so it's very unlikely that you'll have to do it again. There are clients that I see who do relapse and who do require multiple hospitalizations. And even in those situations, it's like it's part of their process. It's not that they're a failure. It's not anything bad. It's really they just needed it in order to get to the next level in their recovery. But for most clients, if they do follow the recommendations and they do kind of work the treatment, it's really a short-term investment for much long-term gain, right? So if we ignore recommendations and we put our health last, any person is going to suffer for that in the long run. It may feel like a quick fix now to avoid the treatment, but later on down the road, those symptoms will gear up, they continue to interfere with our functioning, and we actually end up worse than we would have if we would have just done the treatment when it was recommended. So inpatient can be very scary, and so can residential. Essentially it's packing up your belongings and going to, trust your life in the hands of some other professionals or experts in the field. And you may not even feel like you actually have a problem. And so in that instance, I talk with clients a lot about, and families about, at this point, your life may be in danger, or is in danger. I mean, I don't mess around. If it really is a life and death situation, I will tell my clients this is life and death. And I am in the business of saving lives. And so I will tell my clients and their families that this is something that absolutely has to happen if we want the best shot for this person to not pass away from this eating disorder. So trusting the process is huge, and it's so hard to do. It's much easier said than done. But this is the point in treatment where I see clients really having to let go and surrender and just trust the professionals. Because at this point, when left up to them, they truly end up hospitalized. And so the eating disorder is doing much of the thinking for them and much of the decision making for them. And so we have to work really hard not to fall into that trap or be manipulated by the eating disorder, and to really start making decisions in the best interests of our loved ones, even if it's really hard. So the next step down from there is partial hospitalization. So usually clients will step down. If they start at the highest level of care, they move through the different levels. So if someone was inpatient, for example, then they would move to partial hospitalization. So like I said, inpatient's usually about 3 weeks, give or take, just depends on the person and the individual details of everybody's situation. But then what we see is a step down to partial hospitalization. So sometimes when people are at the residential or inpatient level of care, it can mean that they require a feeding tube or, like I said, a team of round-the-clock professionals just monitoring their health and safety. At the partial hospitalization level, those same supports can be provided. The difference is that instead of staying the night at the hospital, the person is able to go home and sleep. So they start out early in the morning, usually before breakfast, and then they program throughout the entire day all the way through dinner. So most partial hospitalization programs are about 12 hours long and 7 days a week. Going home at night is kind of like that new thing for someone who's been hospitalized at the inpatient or residential level, and it's a big transition. Going home at night, maybe it might be the first time that that individual is faced with all the triggers of the environment that they came from or that they left, essentially, to go get treatment. The treatment team usually will help the client navigate that. So you're going home, you're going back to your room, you're going back to your house, you're going back to your family tonight. What's that going to be like? Let's talk about what kinds of feelings that might bring up for you, or even reminders of what it was like to be in that space while you were much deeper in the eating disorder just a few weeks ago. And so that level of support to help the client transition is absolutely provided at most treatment centers. Eventually, the client will go from 12 hours a day to less and less time at the partial hospitalization level. But just so you have an idea of what to expect, the programming for someone who's inpatient and partial when they're doing eating disorder specific treatment is very similar. So they'll start out the morning with breakfast, and then they might process with one of the team members, like, what was that meal like? What was hard about it? What was easy about it? What was I feeling during that meal? Those types of things, just to bring awareness to the actual process of eating and how the eating disorder kind of takes advantage of that experience. And then they may go from like a group to another group, and then maybe to an individual therapy session or have a family therapy session. And the groups that are usually offered at eating disorder treatment centers have a lot of use. There's all different kinds of skills that clients will learn, and there's different modalities in which they will be exposed to. So some of it might be, talk therapy within a group setting. Other times it might be art therapy within a group setting. Other times it could be recreational types of therapies. So there's many modalities offered in the hospital setting because, it takes creativity and different types of outlets to really help someone who's struggling with an eating disorder. Once the person is ready to kind of reduce the amount of time spent at partial hospitalization level, they will be able to go home earlier and earlier. So it's kind of like this gradual decline in the time spent at the hospital and a gradual increase in the time spent at home or at work. Usually it's at home though. So instead of maybe programming 12 hours a day, they might leave before dinner. And so now they're practicing having dinner at home and maybe a snack at home. And so they get to really work through that. What was it like to eat at home and to prepare that meal? For parents, what was it like to plan those meals ahead of time and use the strategies that you learned while your child was here, and generalize them to the kitchen at home? What did you do? What worked? What didn't? And so there's a lot of support that's given before the child is then usually discharged, or even an adult, because the spouse will be involved. So the adult won't be discharged until they've had enough practice with what that can look like at home. And so once someone is ready to step down from the partial hospitalization level of care, they usually are recommended to go to intensive outpatient. And so intensive outpatient is less treatment. So as you notice, we just kind of do less and less time in the hospital setting and more time at home or at work. And it usually lasts about 6 to 8 weeks is kind of what I've seen on average. So let me just recap. So residential is more long-term. It can last up to a couple months or a few months sometimes. Inpatient is a few weeks. If someone doesn't need residential, but they just need to be stabilized, for a certain reason, they might just start with inpatient. If they don't need inpatient and they just need partials, that's going to be 12 hours a day, 7 days a week usually, for about 8 to 12 weeks on average. And then IOP, or intensive outpatient, usually is about 6 to 8 weeks. And so what this looks like is maybe 3 days a week, and maybe it's after school programming or after work programming, so like late afternoon. So it might start at maybe 4 in the afternoon and go until about 7 or 8 o'clock at night. And it's just for a few days a week. And so what that does is it allows the person to kind of get back into the swing of things. They're living back at home. Their family has more exposure to what an eating disorder is. They learned through family therapy or through education at the hospital program kind of what to say, what not to say, how to support the person at home. And now the individual is ready to go back to school or to work. And at the same time, they also know they have that space 3 times a week to come to a group setting to get support from the leaders in the treatment setting, but also from their peers in the group on, hey, this is what it's like. Maybe I had an urge to engage in a purging behavior this afternoon. I was, maybe on my lunch break, and instead of eating, I decided to go for a walk, and then it turned into a run. Or I'm finding that whenever I'm at home, I feel really triggered by the mirrors in the house, and I don't want to look at myself. So just different things that can come up in that setting, and IOP is intended to really support someone enter really the beginning stages of what recovery is going to look like when they no longer have the hospital team to support them several times a week. And during the time that someone starts intensive outpatient, it's also recommended that they start setting up their outpatient team as well. So outpatient is what I do. I do all outpatient treatment right now at Next Steps and in the Red Clinic. And basically that consists of having a psychologist or a therapist and a eating disorder specific dietitian, and then a psychiatrist who can follow you outpatient once you're done with the hospital treatment. And so that's about once a week with the therapist. It's about once a month with the psychiatrist, and it's usually about once a week with the dietitian. And so if you think about it, someone who's like truly stepped down through all the levels of care ends up going from being in someone's care, 24 hours, 7 days a week, to then 12 hours a day, 7 days a week, to then maybe 9 hours a week, to about 2 hours a week. And so that jump from 9 hours to 2 hours a week is usually the one where we see a lot of stress. So when we see that jump happen, what we notice is the client is so used to having that much support, and then they all of a sudden go down to almost just a couple hours a week. That's usually when a client is more susceptible to falling into old habits. When stress levels are really high and we're pulling the client from their protective bubble of treatment, the eating disorder can get louder. And what I mean is that's when they're most vulnerable to maybe even showing red flag behaviors or even relapsing. And so it is so essential that outpatient team is set up in enough advance notice. So while the person's still in IOP, or even when they start IOP, getting the outpatient provider set up is so important so that the outpatient providers can work with the IOP team at the hospital. They can collaborate. They can start to get to know the client really well, and they can plan a transition for that client. So once they do go from 9 hours a week to just 2 hours a week, it's smooth, it's seamless, and everybody is prepared for it. Because the best way to prevent a relapse is to plan ahead. It's to get prepared for those moments when we know the person's going to need more support. Now, setting up that outpatient team can be really hard to do. There are not a lot of people out there who have expertise in eating disorder treatment. Navigating the outpatient treatment world can be super difficult. Fortunately, there are many treatment facilities across the country that do the higher levels of care for eating disorders. There are not that many providers outpatient that know how to do it. So my general advice and recommendations about this is to make sure that you take the approach of kind of like shopping around or interviewing. Because there are a lot of people out there who do say they treat eating disorders when in fact they maybe never had a lot of experience working with clients or never had any formal training in the area, and would like to maybe work with eating disorders but just don't have that knowledge base. And so we see this a lot with therapists and psychologists, so people in my own profession, but we also see it a lot with dietitians. There are many dietitians out there who will report that they do treat eating disorders when in fact they don't really understand the complexity of the disease. And so with that being said, it's very important first to really do your due diligence and meet with the provider that you're thinking about going to see, and understanding what their level of expertise is. It's okay to ask, how long have you been doing this? Why did you choose to work with eating disorder clients? What can you tell me about your treatment approach? And you just really want to listen for maybe how confident they seem, what their plan is going to be, and what you're looking for when you ask about what their plan is for them to say something like, I wholeheartedly believe in a multidisciplinary approach to treatment. I know that I can't do this on my own because we're fighting an eating disorder. These are the team members that I will include in your treatment and see if they're going to include a dietitian or if they're going to include a psychiatrist. See what efforts they'll make to understand your eating disorder, because every eating disorder is different and unique. And see what their philosophy is on food and health, and even collaborating with other providers. Now that brings me to one of the trickiest things about outpatient is that team collaboration. So, if the client is an adult, they have to kind of navigate this on their own. If the client is a child, then this is a call to all parents who have kids with eating disorders, is to make sure your team is talking to each other. So when you're at the hospital setting, it's kind of done for you. It's taken care of. Everybody's under the same roof. They talk to each other regularly. Usually for most programs, they're meeting maybe 3 or 4 times a week, just talking about the patients and what the next steps are going to be. And so a lot of that is already done for you. When you get to outpatient, if the providers aren't talking to each other, the eating disorder can really take over. And so if the client is saying one thing to the psychologist, but maybe reporting something differently to the psychiatrist, and the psychologist and the psychiatrist aren't speaking, it can be very easy for that eating disorder to ramp back up and to go undetected for quite a long time. And then we set ourselves up for relapse and having to be rehospitalized. So going out of your way to sign releases of information, to insist that your providers are speaking to each other, is really a critical aspect to outpatient treatment. Now, at the Red Clinic, we actually do have a multidisciplinary team under one roof. It's really unique to outpatient. It's not really happening anywhere else. And so for us to have the psychologists, the therapists, the dietitians all under one roof and doing regular weekly treatment team collaboration is more modeled after the hospital setting on purpose. So when I created that protocol, it was because I knew the best care for our clients is one where we are cohesive and collaborating regularly. And so our clients don't have to worry about that at the Red Clinic. Many times clients will ask if they can skip levels of care. And the answer to that is that it's not recommended. When a client steps down, like I said, from partial hospitalization to intensive outpatient, they can feel pretty burnt out. Like many clients are ready. They're just, I'm done. I want to get back to school. I want to get back to work. I'm sick of treatment. Many clients are struggling with eating disorder thoughts during that transition, and they may feel like they just want to be left alone so they can go back to the eating disorder and not have to worry about anything anymore. And so skipping that level of care is absolutely not recommended. Clients come to me all the time and they say, why can't we just start seeing you outpatient? You know, why do we have to do this 9-hour-a-week thing? It's going to be so stressful. I have to go back to work or school. Then I have to do this 3 nights a week. And then I have to come see you and the dietitian another couple hours during the week. It's just insane. I don't want to do it. I can't do it. And I tell my clients all the time, if we skip levels of care, essentially you're asking me to treat you in 2 hours a week when you really need 9 hours a week. It's kind of an impossible situation. And it's a setup for failure. It's definitely set up for a relapse, for that eating disorder to kind of come back loud and proud, and for us to not have done the treatment correctly. And so when I see clients who do skip levels of care, because for whatever reason they just feel like they want to do it their own way, which happens, I do see them quickly have to go back to the higher levels of care because things got too stressful too fast and the skills weren't in place to really help them through the ramped up eating disorder thoughts and feelings. So I don't recommend that. Now, there are many times when clients will come to me outpatient and they get an initial assessment. And so we've never met before. I may never have worked with the client in the past. This is maybe the first appointment, and I'm doing an assessment and I realize this client is not appropriate for outpatient. And so the reason for that is like I said, you know, physically, medically, psychologically, they may just not be at a place where they're going to be able to do this with just 1 or 2 hours a week. Sometimes we do need to shock the system just enough to help people bust out of those routines. And if the eating disorder has a grasp on someone to the extent that, hey, as soon as they leave my office, I know they're going to go right back into their old ways, I'm not going to waste anyone's time. And so I tell clients that, you know, I'm not going to waste your time. I'm not going to say, hey, let me treat you for an hour or 2 a week and see how it goes, when I can already tell based off of everything that you've told me, this is not going to work outpatient. So I let them know that right away. I also don't mess around because in the case of extreme malnutrition, I do know that, you know, anorexia, for example, is the #1 killer across all mental health diagnoses, especially in adolescent girls. And so I do not want to ever keep someone outpatient if it's not clinically safe for them to do so. So know that anytime a provider makes that recommendation to go to a higher level of care, it's not to be annoying, it's not to disrupt your life. There's nothing in it for them except they're just truly concerned And because you can trust them, they're actually sending you away. So getting stabilized is really important, and it needs to happen first before the outpatient work can really begin. When a person is truly ready for outpatient, that's when some really amazing things can happen. That's that transformation that I think I live for and thrive off of, and what makes me so passionate about this work that I do. Because when clients are inpatient, I mean, they're literally at the point where they're fighting for their life. I can't tell you the stories that I've come across individuals, who are maybe at like 50% ideal body weight, and they're literally on their deathbed, and they're pushing around a feeding tube, the little pole, because they have a feeding tube, and that's the only way they're getting their nutrition. And that eating disorder just has so much power and control over them. And then they get to the point where they're outpatient, and they've done the work, and they've healed, and they're in true recovery. And they're doing things to make a difference in this world. They feel better about themselves. They've found who they truly are. And it's just really beautiful. It's so enjoyable to be a part of that. And that's why outpatient is so, so rewarding for me. And at the same time, I'm not even going to go there with the patient unless it's actually time for them to do that. So that's what I have with levels of care. I hope this podcast answered some questions, put your fears at ease a little bit. I like to give people an idea of what to expect at the different levels of care, just because I know it can be scary. I've sat with many families before when I've had to tell them, you need to go to the hospital. This is not safe, to stay outpatient. And it's really scary. And it's really normal, too, to start thinking, like, how am I going to even do this? How do I get time off of work? How much school is my kid going to miss? I recommend that even though it's normal to go there, you try to stay focused first on you're saving someone's life if you follow the recommendation. That's it for today. Thank you for tuning in to the Red Clinic Podcast.